Welcome to our video on Acneiform Eruptions. In this lecture, we'll be discussing three dermatologic conditions: acne vulgaris, rosacea, and hidradenitis suppurativa. We will be discussing the definition, pathophys, risk factors, clinical presentation, diagnosis, and management. So let's start with the definition of acne vulgaris. Acne vulgaris is a condition that results from excess androgens, and we see it most commonly in adolescents, though adults can have it as well. It is characterized by various lesions throughout the disease process, including comedones, papules, pustules, nodules, and cysts. Let's illustrate the pathophysiology of acne vulgaris. It all begins with hyperkeratinization, where the follicular cells stick to each other and don't shed properly, leading to plugging of the hair follicle, and that's a process known as comedogenesis. Topical retinoids, the initial treatment for acne, work by inhibiting this process. If the keratin plug is located below the skin, it is referred to as a closed comedone or whitehead. If the keratin plug rises above the skin, it's called an open comedone or blackhead, which will have a darkened color because the melanin pigment is oxidized when it's exposed to the open air. The keratin plug traps sebum below the skin's surface, which is an energy source for the bacteria, especially Cutibacterium acnes. As this bacteria consumes the additional sebum, inflammation occurs. It is this inflammation that gives the papules and pustules that we often associate with acne. If the inflammation goes on too long, the follicle may rupture and give nodulocystic acne. This slide breaks down the diagram just shown. Put simply, acne vulgaris begins with hyperkeratinization and plugging of the hair follicle. This results in sebum trapping and subsequent proliferation of Cutibacterium acnes bacteria. This bacterial proliferation results in inflammation and possible cyst rupture, if not well treated. The risk factors for acne vulgaris are mostly those things that increase androgen levels. Primary risk factors for this would include male sex and puberty. Secondary risk factors for excess androgens include PCOS, or a tumor of the ovary or adrenal gland. Glucocorticoid use can also result in acne. You may also see this referred to as steroid folliculitis. Finally, Cushing syndrome may lead to acne in some patients. There are three characteristic presentations of acne that you should be able to recognize on a physical exam alone. And these are comedonal, inflammatory, and nodular or cystic. Let's turn to a few images to help make this clear. Here we see a classic image of a teenager with acne vulgaris. You can see closed comedones, also referred to as whiteheads, scattered throughout that image. This would be comedonal acne. Additionally, you can appreciate areas of marked erythema with some papules, which are raised, and you can see those inflamed areas. These are characteristic of inflammatory acne. Notice that this person's skin also appears to be very oily, which may predispose patients to acne. Here we see another image of a patient with acne. In this case, we see more of the nodular and cystic appearance that this dermatologic condition often exhibits in later stages, after follicular rupture occurs. Keep in mind that question stems may ask about acne in a couple of different manners. They may mention various risk factors in the stem before showing you a picture of the rash and asking about treatment. Alternatively, they may tell you in the vignette that the patient has acne and then ask for the most likely cause. Speaking of questions, let's answer a question now. How can we differentiate a patient with glucocorticoid-induced acne from a patient with traditional acne vulgaris? So there's actually multiple ways of answering this question. So we'll actually highlight that on the next slide. Okay, this is a question that wants us to be able to distinguish two commonly encountered types of acne. Here we've chosen to break these down by three characteristics: the location of the lesions, the appearance of the lesions, and the response to therapy. With this information alone, you should have no trouble answering a step question on the topic. Now, for glucocorticoid-induced acne, the lesions are primarily found on the upper back, shoulders, and upper arms. And this is different from traditional acne vulgaris, which is most commonly seen on the face. Now, the lesions look different in both of these conditions. In steroid-induced acne, the lesions appear as monomorphic papules, and comedones are absent. Let's quickly look at an image of this to compare with the images of traditional acne vulgaris shown earlier. Before I go any further, I'd like to mention that these images were contributed by Amboss. So, thanks to our partnership with Amboss, I can highlight several important features of steroid folliculitis. And here we see an image of a young female who had received high-dose methylprednisolone, and that was going on for a week. And then she developed steroid folliculitis over her back. Note the location and appearance of the lesions. As was mentioned, the back is very commonly affected in these patients, along with the shoulders and upper arms. Hopefully you can appreciate that the papules each look relatively similar, and we don't see the characteristic comedones that would accompany acne vulgaris. Contrast the image of glucocorticoid-induced acne with the first image of traditional acne, shown where the lesions existed in various stages. Now, both comedones and pustules were present on the face at the same time. A final distinguishing characteristic is that the response to therapy is different. Glucocorticoid-induced acne won't respond to traditional acne medications. Instead, the offending agent needs to be discontinued. Traditional acne, of course, responds to traditional acne therapy, the specifics of which will be discussed in a few slides. Another possible answer to this question would be that traditional acne is more commonly seen in adolescents, while glucocorticoid-induced acne may be seen more frequently in adults, such as those that are taking steroids for treatment of a chronic medical condition. Acne vulgaris is primarily a clinical diagnosis based on the well-recognized appearance shown previously. That being said, we should always be on the lookout for other signs of androgen excess, such as a female patient that develops hirsutism or clitoromegaly. In these cases, we need to consider secondary causes, such as adrenal or ovarian tumors, congenital adrenal hyperplasia, and polycystic ovarian syndrome. A few tests that you could order to begin this workup include testosterone, dehydroepiandrosterone sulfate, and 17-hydroxyprogesterone. The specifics of each of these diagnoses are discussed in other lectures. Time for another quick question. A 21-year-old woman with a BMI of 42 is seen by her primary care physician for severe nodulocystic acne on her face and back. She states that she has had irregular periods for as long as she can remember and expresses frustration over recent hair growth on her upper lip. What is the most likely diagnosis? The most likely diagnosis here is polycystic ovarian syndrome, or PCOS. While PCOS is largely an OBGYN topic, it is pertinent to this lecture because it is a common cause of acne, particularly in those with an elevated BMI. The criteria for making this diagnosis should be committed to memory. To diagnose PCOS, 2 of the following 3 criteria must be met. The first is menstrual irregularities, the second is hyperandrogenism, and the third is polycystic ovaries on ultrasound. This patient meets the first criteria by having had irregular periods for as long as she can remember. She met the second criteria because she has severe nodulocystic acne and hair growth on her upper lip, both of which are evidence of hyperandrogenism. And a more detailed explanation of this disease process can be found in our OBGYN lectures. Let's review the management. This is frequently tested, so pay particular attention here. The first point to make is that these treatment options should follow a stepwise progression. That is to say that each successive medication should be tried before advancing to the next one. The initial treatment includes topical agents, and we then switch to oral agents for more severe cases. Topical benzoyl peroxide, or topical retinoids, can be used first. Each of these should be applied after the face has been well cleansed. Topical antibiotics, like erythromycin and clindamycin, can be given if these fail. After that, we would try an oral antibiotic like doxycycline or erythromycin. So you can see we're transitioning from topical to oral now. Then if all else fails, the patient can be given an oral retinoid agent. To remember this latter of treatment options for acne, you can think of the mnemonic RAAR, like the sound of an angry lion might make if they were woke up and they had acne. Rar. Well, the letter R stands for retinoids, and the letter A stands for antibiotics. From there, just remember that the first 2 options are topical agents, and the next 2 options are oral agents. And if you can remember that, you'll be golden. Here we'll highlight a couple of additional points regarding acne management. It is important to know that isotretinoin, the oral retinoid given for cases of severe acne, is highly teratogenic, and thus requires 2 negative pregnancy tests before it starts to be administered. Additionally, patients are required to use 2 forms of birth control, oral contraceptives and condoms, for example. As far as general principles of acne management, it's important to clean the affected area regularly, and oral contraceptive pills may be helpful as a treatment for some women. Next, we'll cover rosacea, and here's the overview of how we'll cover each condition again. Rosacea is a dermatologic condition with various subtypes that most commonly affects the nose and central face. The forms of rosacea include erythematotelangiectatic, papulopustular, phymatous, and ocular, and it's characterized primarily by erythema and flushing. The exact mechanism of rosacea is not well understood. Some proposed components of the pathophysiology include immune system dysfunction, an inflammatory response to organisms in the skin, UV radiation, and hyperreactive vasculature. As far as risk factors go, the vignette will tend to give a middle-aged female with fair skin. Each of the other items listed on this slide may trigger a worsening of the rash. This includes sunlight, alcohol, hot beverages, emotional stress, and spicy foods. The exacerbation of this rash in the heat is in stark contrast to the rash of keratosis pilaris. This is a rash that is often brought on by the cold. It is most commonly seen in children as small papules appearing on the back and upper arm. Rosacea is sometimes referred to as adult acne because the appearance is somewhat similar. Now, the absence of comedones helps distinguish the two. The classic rash involves a reddening of the nose and cheeks with possible telangiectasias. Let's take a quick look at this. Here we see an image of a patient. Notice first the erythematous nature of the rash and its location over the cheeks and nasolabial region. In this case, we can also appreciate an area of telangiectasias and a few inflammatory papules and pustules. Given these features, this patient has elements of the erythematotelangiectatic and papulopustular subtypes of rosacea. Finishing up the clinical presentation, this is a rash that often comes and goes based on the presence or absence of the inciting factors that we mentioned earlier, such as sunlight or alcohol. Patients often describe an uncomfortable burning sensation over the area where the rash is present. What has been described to this point is the classic presentation of rosacea. It is also possible for patients to have ocular involvement, such as blepharitis, keratitis, or a foreign body sensation within the eye. We call this ocular rosacea. Finally, patients may get an irregular thickening of the skin, particularly the nose. This is called phymatous rosacea. Here we see an example of rhinophyma, which is an example of phymatous rosacea, one of the possible manifestations of rosacea. Notice that the skin has become thickened and disfigured, particularly over the nose. There are also small dilated vessels. Rosacea is a clinical diagnosis that's made based on the history and physical exam findings that we just outlined. To manage this disease, we start by limiting the inciting factors. This means cutting back on alcohol, hot drinks, sun exposure, spicy foods, and any other triggers the patient may have. The next step would be to try a medication. We often start with topical metronidazole. Other less common treatments that are first line would include azelaic acid and ivermectin. Topical brimonidine is effective for those patients with facial erythema. Now finally, in severe cases, we may treat patients with oral tetracyclines, such as doxycycline. A 46-year-old female comes to the physician due to a facial rash that started 4 months ago. The rash is bright red and involves her nose and cheeks, and it worsens when she eats spicy foods, goes out in the sun, or consumes alcohol. She has a history of untreated strongyloidiasis. What is the best treatment for this patient? This middle-aged lady presents with a bright red facial rash involving her nose and cheeks that worsens with spicy foods, sunlight, and alcohol consumption. This presentation is most consistent with rosacea. First-line treatment for rosacea is topical metronidazole, azelaic acid, or ivermectin. Given that this patient has a history of untreated strongyloidiasis, ivermectin would be the best choice, since it's first-line treatment for this helminth infection. And we can supplement this treatment with topical brimonidine if the facial erythema is a primary concern. Given their unique relationships with the weather, it's worth quickly comparing and contrasting the rash of rosacea with that of keratosis pilaris. The exacerbation of this patient's rash when she goes out in the sun is in stark contrast to the rash of keratosis pilaris. Keratosis pilaris is a rash that is often brought on by the cold, and it's most commonly seen in children as small papules appearing on the back and upper arm. So we revisited this idea of comparing dermatological eruptions or acneiform eruptions to keratosis pilaris to really help you identify these small clues, because small clues like these are critical to answering step 2 questions correctly. We'll finish the lecture by talking about hidradenitis suppurativa. Hidradenitis suppurativa is a dermatologic condition involving the intertriginous areas. It is characterized initially by inflammatory nodules. Throughout this chronic condition, these nodules may progress to abscesses, sinus tracts, and even scars. Let's take a look at an image of this to begin with, since this may be a condition that you're less familiar with. Here we see an image of the right axilla of a patient with hidradenitis suppurativa. Perhaps most important with this condition is being able to recognize what it looks like. Notice that this patient appears to be obese and female, which are both risk factors for this disease that will be highlighted later. Hopefully, you can appreciate some of the nodularity and scarring that often accompanies this disease within this image. The pathophysiology of this disease isn't entirely unique from that of acne vulgaris. Patients get repeated occlusion of the hair follicles, leading to recurrent inflammation. The risk factors for this disease are fairly straightforward. Female gender, smoking, diabetes, obesity, and a family history of the condition can all play a part in someone developing this. As far as the clinical presentation, be on the lookout for persistent and recurrent lesions that began as nodules. After the initial nodules present, patients may go on to develop abscesses, which are often malodorous. They can develop sinus tracts and significant scarring. Now, this prominent scarring creates a concern for lymphatic obstruction. In the vast majority of cases, the axilla or groin region is involved. As with many dermatologic conditions, this is a clinical diagnosis based on the classic appearance shown earlier. A 40-year-old female patient with a history of obesity and type 2 diabetes mellitus comes to the physician because of difficulty moving her right arm. She states that it feels heavy. Her symptoms began about 1 month ago with swelling in her armpit and have worsened since then. She has smoked 2 packs of cigarettes per day since the age of 15. Physical exam reveals nodules and sinus tracts in her axillae. What is the most likely cause of her right arm swelling? Now, this middle-aged lady with obesity, type 2 diabetes mellitus, and an extensive smoking history now presents with right upper extremity swelling, accompanied by nodules and sinus tracts in her axillae. This presentation is consistent with hidradenitis suppurativa. Now, the question asks what the reason for her right arm swelling is. This patient's diagnosis has already led to sinus tract formation, which can result in fibrosis and scarring, leading to the development of lymphatic obstruction. As the lymph accumulates, patients get resultant swelling, heaviness, and decreased mobility in the affected arm. In her case, this is what has probably occurred within her right axilla. The treatment of this disorder is very similar to acne vulgaris. We start with a topical agent like clindamycin for mild disease, and we can move up to oral agents, antibiotics, and retinoids for moderate disease. In severe cases, surgical drainage may be required to clear the abscesses and sinus tracts that may form in these patients. Let's wrap up with a board-style question. A 38-year-old female comes to the physician for a facial rash that she hasn't had since she was a teenager. She first noticed the rash 2 weeks ago. Her past medical history is only significant for mild persistent asthma treated with albuterol, salmeterol, and low-dose fluticasone. Her temperature is 37 degrees Celsius, blood pressure is 115/70, heart rate is 80 beats per minute, and respiratory rate is 15 breaths per minute. Physical exam reveals cysts and nodules with significant scarring on the face and the upper back. Her BMI is 23. Her periods occur every 28 days. The remainder of the physical exam is unremarkable. Laboratory findings are significant for high levels of dihydroepiandrosterone sulfate, or DHEA-S. CT scan shows a suprarenal mass. What is the most likely cause of this patient's physical exam findings? A. Adrenal tumor. B. Polycystic ovarian syndrome. C. Cushing's syndrome. Or D. Glucocorticoid use. So here we have a middle-aged female who presents with a facial rash that she last had when she was a teenager. Physical exam reveals cysts and nodules with significant scarring on the face and the upper back. This presentation is consistent with nodulocystic acne. And acne can be caused by various conditions. And when it starts very quickly, such as in this patient where it has happened rapidly progressing over 2 weeks, you should first think about an androgen-secreting tumor. Now, this patient has high levels of DHEA, which is the primary adrenal androgen, and her CT scan shows a suprarenal mass. Therefore, she likely has an adrenal tumor, and the correct answer is choice A. This is the slide that we discussed earlier in the lecture reminding us of secondary causes of acne. Let's now discuss why the other answer choices are incorrect. Answer choice B, polycystic ovarian syndrome, can certainly cause acne due to hyperandrogenism. However, PCOS is usually characterized by slower onset of acne and obesity and irregular periods. And this is not true of this patient who has irregular periods and a BMI of 23. Answer choice C, Cushing's syndrome, is possible because Cushing's syndrome can cause signs of hyperandrogenism, like acne, and this patient has a suprarenal mass on her CT scan. However, Cushing's syndrome is characterized by additional physical exam findings, such as purple striae, central obesity with thin extremities, round facies, and supraclavicular fat pads. And these findings are absent in this patient, which makes it less likely than an adrenal tumor. Now, answer choice D, glucocorticoid use, can lead to the development of acne. This patient is taking low-dose fluticasone for her asthma, which may make this an attractive answer choice. However, recall from our previous question that steroid-induced acne is much different in appearance from the nodulocystic acne described in this vignette, making this less likely. So again, the correct answer is A, adrenal tumor. And that concludes this section.